now. So thank you very much. This is inshallah a third GI serial or 4 GI serial lectures. As I said earlier, the goal is to cover a neonatal board review by the Dara Broditsky, and I try to make it easy and try to cover the whole aspect of this book to let you guys be ready for the board, whether it's American board or Arab board, inshallah. Again, my name is Dr. Benayat, and for who doesn't know, I have YouTube channels. All those lectures, inshallah, is going to be uploaded on the YouTube. And feel free to subscribe if you like it, so you can receive and notify if there's a new lecture, you're going to receive it, inshallah. Again هذا كملنا الريسورس نتاع البرزنتيشن من الامريكان اكاديمي بيدياتريك كوريكولومز ولكن mainly from the Broditsky. I have the second edition. Inshallah, I already in the Facebook I already upload the serial textbook at the PDF form. Feel free to download the third edition so you can follow with me, inshallah. So there's two parts of this presentation. Part one, I'm going to talk about the pyloric stenosis, and also I'm going to talk about the small bowel obstructions, duodenal atresia, ileal or jejunal-ileal atresia, and then I'm going to cover the malrotation and volvulus, and then meconium ileus and meconium peritonitis. And next week, we will cover the large intestine and the anus. This in the picture, one of the conference, American Academy, as was third year with my colleagues, fellows. And this one, Dr. Van Roof, everybody should know this guy. He's the kind of like the father of the neonatologist. The textbook of the Van Roof, that's well known, like Nelson textbook for pediatric. This is well known for the textbook for the neonatologist, Dr. Van Roof. He's well known and he's very smart guy. So the learning objective of this to review the differential diagnosis for bilious and non-bilious vomiting, and then understand each one and management aspect. So before, it's very important to be organized. Each time you have a jaundice, you need to organize what the differential diagnosis of jaundice. If you have a vomiting, you need to organize yourself. So at least the way you think, it's make you smart and make you approach in the right way. So whenever you have a vomiting, you're gonna ask yourself, or you're gonna ask the parents, whether this vomiting is projectile vomiting or non-projectile vomiting. The reason why, because if the baby has a projectile vomiting, then you think that anything obstruction from the usually around the second part, so before the villi of the bile, so you're going to be anything above this area. So so that's anything here, obstruction. Usually it causes projectile vomiting, non-bilious, and non-projectile vomiting, which is what does it mean? Either gastric outflow obstructions or increased intracranial pressure. So whenever you have projectile, it means the baby is vomiting far away, like projectile, think of either number one, gastric outflow obstruction, or baby has increased intracranial pressure. Increased intracranial pressure is a little bit rare, so always think of the gastric outflow or outlet obstructions like pyloric stenosis. If you have non-projectile vomiting, then the differential diagnosis is wider, and that's the commoner, okay? The non-projectile vomiting, the question is either bilious or non-bilious vomiting. If obstruction just below the ampulla vata, then you think of the projectile. Why? Because of obstruction, the bile is here coming out, and then babies, when he have obstruction, the food accumulated, and the baby is going to have, everything is going to come out as a bilious. Versus non-bilious vomiting, anything below the second part of the duodenum. Okay, so bilious, non-bilious, low baby have non-projectile vomiting. Non-bilious vomiting, then whether blood or non-bloody. Really, whether Dr. Ayman,
لحظة بس.
Please mute the phone. Non-bilious vomiting, whether bloody or non-bloody. Is it important to differentiate the differential diagnosis? No, it's not important. It's important to know bilious and non-bilious. It's important to know whether mixed with blood or no, but it's not going to help you with the differential diagnosis. But in order to differentiate yourself, the most important, projectile, non-projectile, and then if projectile, you know it's gastric outflow obstructions or outlet obstructions or increase in intracranial pressure. If you have a non-bilious vomiting, then it could be, non-projectile, then it could be either bilious or non-bilious vomiting. At least you know this, where's the location of the obstruction. Projectile vomiting, that means comes all the way from the gastric acid. So that's why usually, that's funny cartoon, that means it's burning because of acid. Let's talk about the first differential diagnosis is projectile vomiting. Whenever you hear projectile vomiting, first comes in your mind the pyloric stenosis. So pyloric stenosis, that means it's the postnatal. Something is not antenatal. It happened postnatal hypertrophy or hyperplasia of the antrum or the pylorus, the muscular layer of the pylorus. Okay, the incidence is around 3 to 1,000. So each 1,000 baby around 3. The most character, the board review, they like it, male more than female. You have 5 times male more than female. And then firstborn male. That's the always, even during pediatric, we know, during the 5th year, they always ask first male, first baby, or firstborn male. We said the cause, it's exactly unknown, but there is mix between, it could be environment or hereditary factors. It's mixed. We don't know which one is ones. Based on what we said, that could be environmental or it could be hereditary. The hereditary, because we know that if the mother had pyloric stenosis, there is 19% or close to 20% chance that her son will have pyloric stenosis. So if the mother had it before, if the mother she had in the history, she had pyloric stenosis, there's 20%. If this baby born boy, there's chance of 20% that baby will have also pyloric stenosis. If the baby is girl or daughter, then the chance is 7%. So if the mom, she had history of pyloric stenosis before when she was a kid, then the chance that her delivered baby with pyloric stenosis is higher. So that's number one. And we said if the boy, then it's almost double. It's going to be around 20% versus 7% if the girl. That's number one. If the father had pyloric stenosis before, should be had, not has, pyloric stenosis before, then 5, almost 6% risk that her baby will be, if the boy will be pyloric stenosis, 2.5 or 2.4% that if the girls will be pyloric stenosis. So chance is less. If one child, if her first child is going to ask you, okay, now you have the baby who is pyloric stenosis, the mom, she's going to ask you, what the chance that the next generation or next child will have the pyloric stenosis? 3%. Based on this information, the hereditary come in the board. Okay, so that could be hereditary, number one. What about the environment? The environmental factors, there is link between the pyloric stenosis and infantile hypergastrinemia. There is possible abnormality in the myenteric plexus innervation, higher risk in patient with cow milk protein intolerance. But it's more important for the board that risk in the baby, if the baby received the macrolide like erythromycin, especially in the first 2 weeks of life, the chance that baby will have the pyloric stenosis increase. And that's based on the 9 meta-analysis review study. That baby who's receiving pyloric macrolide group, erythromycin or azithromycin, the risk for pyloric stenosis increase, especially in the first 2 weeks of life. Okay. Also, what's interesting, also, if the mom, she used the macrolide group during the first week of birth, after birth, also her baby, especially if the breastfeed, increase the risk of the pyloric stenosis. Based on this information, what's the statement or recommended is very important to monitor any baby who is receiving erythromycin or azithromycin Also, which is interesting, prostaglandin infusion in the first few weeks can also increase. So etiology, just to summary, etiology of the bile duct stenosis is still unknown. There is environmental factor can contribute. Also, there is hereditary factors. It could be mixed, we don't know. But what we know, it's postnatal. It's not something baby born with. It's something, it happens postnatal. Okay, also, and that's the articles, JAMA 2013, researcher identified that baby who has low cholesterol level or low serum lipid are higher risk for pyloric stenosis. Or the babies who have pyloric stenosis, they note that they have low cholesterol level. It's invert related with, so that means pyloric stenosis. Sorry, pyloric stenosis inverted related with cholesterol level. Okay, nobody knows why. Okay, so what's the presentation of the pyloric stenosis? We know it occurs in the first few weeks of life, up to 5, some they said up to 6 months of age, but typically usually around 3 to 6 weeks of age. As we said, usually they present a typical history of projectile non-bilious vomiting. Very important, projectile non-bilious vomiting. Sometimes if baby severe projectile vomiting, sometimes it can cause tear and baby can have coffee ground or red bright blood. So blood, bloody or non-bloody, does not rule out either. There's chance, yes, small chance that baby might have slightly hematemesis. Okay, it's very characteristic. The babies after vomiting, he feel very hungry and vigorously sucking after the episodes of, that's the clue in the board, in the question if you see it. Very late, if you were not discovered, baby might end up dehydrated, poor weight gain, metabolic affected, usually hypochloremic, hypokalemic metabolic alkalosis, and sometimes baby is completely lethargic because of the dehydration. Okay, so is it every time, always at the beginning projectile? No, it might be beginning just regular vomit, and then as the stenosis or pyloric get worse, then babies develop later projectile, non-bilious projectile vomiting. When exam, that's also can be board question, is not always there, but it's around 60 to 80% of time you can feel it. It's around, it's called olive mass, usually palpable either in epigastric or right upper quadrant. So right upper quadrant or epigastric mass, it's olive-like mass, especially either shortly after vomit or during feed. We prefer to give baby feed and you feel or palpate if this mass. Very good. So from history, you have suspicious based on projectile vomiting, peristalsis movement, visible, especially during feed, or the filth of the shini. You feel the olive palpable mass in the right upper quadrant or epigastrium area. Then once you have the high suspicious, you order immediately ultrasound abdomen. Okay. As a part of the admission or the ER, you're gonna, if the baby came to die, you're gonna do the labs. Usually that's the board question, what's the lab value for? Because baby lose acids is gonna be hypochloremic acid losing, hypochloremic chloride low, hypokalemic metabolic alkalosis. That's very important triad, okay, as a clue. Ultrasound, that's another clue. So ultrasound, you will see muscle wall thickness around 3 millimeter or higher than 3 millimeter. Some they said higher than 4 millimeter, and the length more than 14 millimeters. So thickness of the muscle wall thickness in ultrasound guide more than 3 millimeter in diameter, and the length is the 14 or greater in babies who is younger than 13 days of life. Okay, so what does it mean? When you do the ultrasound, the thickness of the pylorus, it should be more than 3 millimeter thickness. The length, it should be more than 14 millimeter. If you do the transfer view, you will see something called target sign. Okay, target signs. You see like the target. So target sign on the transfer view, longitudinal view, it's very important to measure the length and to measure the thickness and the length. Very, very, so the drug or the diagnostic choice is the ultrasound or the study of the choice. That's the board. The study of the choice is ultrasound, okay? It has high specificity and sensitivity. If the few cases that you are not sure whether baby has pyloric stenosis or no, and ultrasound was not conclusive, then you can do upper GI study. Okay? And when you do the upper GI, it's very characteristic. You will see the bile. So you give the upper GI, you fill the stomach, and then you will see the something called string sign or upper call appearance. So it's like rat tail appearance or the string sign. And that means there is here hypertrophy of the pylorus. So it's barely the dye or the contrast coming out. Okay? Okay, baby came to the emergency room, projectile vomiting. You examine the baby, you highly suspicious this baby has pyloric stenosis, few weeks of life. Baby is hungry after feed. You try to feed the baby and you touch the belly, whether you feel the, you see the peristalsis movement or you feel the olive mass. Sometimes it's hard to feel it, that's fine. It's not all the cases you will see it. You order ultrasound, came back, this baby has pyloric stenosis. Is it emergency? It means I have to open right now? The answer is no. You can, the most important before even to send the baby for the surgery, you need to correct the electrolytes and stabilize the baby. So you correct the dehydration, number one. You correct the alkalosis, hypochloremic, hypokalemic. So you correct it. When I was a resident, we don't call the surgeon middle of night, come and this baby pylorus, you need to do the surgery. No, usually we stabilize the baby. We can do it even the second day. The surgeon can come second day and do the surgery, okay? The surgery, it could be open or it could be laparoscopic. The most recommended is the laparoscopic, okay? And the laparoscopic, what they do exactly, they don't touch the mucosal surface. So this one, they don't touch it. What they make small incision, transfer incision, and then slowly the mucosa expanded. So that means you release the thickness, you make a hole, you release the thickness, so the mucosa, it's open. So this is number one image. This number two, you cut it. This number three, you dilate it, and then everything is come out. And then finally, like that, when you have the balloon or the when you play with the soccer, usually when they have the outside steer, then you can see the internal ball is coming out. That's the way. So now you relieve the obstruction and the muscle is like already released. So that's how it's work with the pyloric stenosis. Usually those cases, you can feed the baby with Pedialyte few hours after, like around 8 hours after the surgery, you initiate feeding. Usually they recommend Pedialyte, and then slowly you advance to the full feed. Hopefully the picture is clear. Okay. There's another differential diagnosis which is close to the pyloric stenosis, that's called antral web. The antral web also, the picture is the same because it's the antrum, is the web around the antrum block the exit. It causes the gastric outlet obstruction called the antral web. The differential diagnosis, we said pyloric stenosis usually postnatal, it's after, it's acquired, versus the antral web, it's the congenital. The antral web, so this one here, pyloric stenosis, and here the antral web. The pyloric stenosis, usually we said anytime after birth, but common 3 to 6 weeks of life. The antral web, usually anytime, you at birth or shortly after birth. The pyloric stenosis, baby born, normal birth weight, versus the antral web, baby, usually small birth weight baby. The pyloric stenosis antenatal is nothing, normal baby, so no polyhydramnios. The antral web, because of obstruction, antenatal, there's obstruction, there's web, usually baby has the polyhydramnios, the amniotic fluid increase, because baby is not absorbed. Both of them, they're gonna give you, because the obstruction up, so before the second part of duodenum or before the bile secretion. So usually both of them, they give you non-bilious vomiting. The diagnosis, usually our diagnostic with more than 90% specificity and sensitivity for the ultrasound for biliary stenosis versus antrum. You're going to do first ultrasound. If it's hard to diagnose, there's no biliary stenosis, then you can do upper GI, and finally you might need the endoscopy. Both of them treated surgical. Is that clear? Okay. So now we cover biliary stenosis. Let's go to the second, which is the most likely we're going to talk about after biliary stenosis. We're going to talk about the small intestine pathology. So we discussed about bilious vomiting. It could be non-projectile, it could be projectile vomiting. Now we're going to discuss about non-projectile vomiting. Non-projectile vomiting, we have a bilious and non-bilious vomiting. Correct? Very good. Non-bilious vomiting could be bloody and it could be non-bloody vomiting. So what's the differential diagnosis of non-projectile vomiting, whether bilious or non-bilious vomiting? We are talking about mainly any baby who's presented with bilious vomiting, and that's, please remember this, bilious vomiting in the neonate, malrotation till improve otherwise. Bilious vomiting in the neonate, malrotation volvulus till improve otherwise. So the first, you have the baby with bilious non-projectile vomiting, you need to rule out the true emergency before you discuss about the others. So your jobs to make sure you be safe physician. So you need to rule out it's the surgical, which is malrotation with volvulus. That's number one. So that's the top of your differential diagnosis, the malrotation and volvulus. Okay. Other differential diagnosis could be intestinal atresia, like duodenal atresia, or stenosis, or ileal atresia, or ileojejunal atresia. You need to make sure, or we discuss about the biliary quip, congenital bands. It could be obstruction from outside annular pancreas, intussusception, which invagination, which is usually older kids. We are here focused on the neonates, meconium ileus, or Hirschsprung disease. We will talk about one by one. Okay, so what's wrong with, let's have a better talk. So what's wrong with you have baby with intestinal obstruction? So you have a baby with either atresia or stenosis or volvulus. What's wrong with having the baby with intestinal obstruction? Number one is going to be the food is going to be accumulated, correct? So you continue feed the baby initially and the food impact. When the food start impact, first, there is always in the intestine, there is always flora, bacteria flora, correct? The bacteria ferment the food because that's the food should be absorbed, stay there, sugar. They eat fermented, what's gonna happen? Produce gas, correct? When the bacteria produce gas, the abdomen start more distended. When the abdomen start or the section of the bowel start distended, what happens? It's gonna here in this area, there is blood supply of that region of the bowel. If we are talking about small intestine, we are talking about the mesenteric, anterior mesenteric artery or veins. So here the blood vessels. So when the bowel starts distended with the gas, what's going to happen is going to make pressure on the bowel. So when it's going to happen on pressure on the blood supply to the bowel, you're going to have the ischemia. And when you have the ischemia, what's going to happen after that? You have two things. Number one, you're going to affect the peristalsis movement. When you affect the peristalsis movement, so here we said, sorry, let me clear it up, make it better. we said when you have a gas, increase intestinal distension or bowel distension. And bowel distension gonna affect your vascular supply. And that's create ischemia. When you have ischemia, what's gonna happen? You slow down the intestinal motility. You're gonna slow down the peristalsis movement. When you slow down peristalsis movement, you further increase the bowel distension because further is gonna be obstruction. That's number one. Also, ischemia, what's gonna happen is the bowel necrosis. When you have bowel necrosis, then what happens? The bacteria is gonna get out and that can cause what? Sepsis, correct? And that's why it's called perforation, either micro or macro perforation. And when you have the perforation, then you might have sepsis. So that's another issue with bowel distension. Also, that's trigger the respiratory, the brain, and the baby start having vomiting just because it's obstructions, backup food, and then baby's gonna have the vomiting. And vomiting is gonna end up dehydration. And dehydration gonna get things worse. So the issue with intestinal obstruction, you will have number one, ischemia. Number two, you're gonna have perforation, bowel perforation, and then spread of the bacteria. That change become more toxigenic or pathogenic bacteria. And then you're gonna have dealing with sepsis. And if the macro perforation, then you're gonna have more pressure, and then you might lose further piece of the bowels. Okay. In general, if the babies have either bilious or persistent vomiting, always we recommend number one, NPO, nothing per mouth. You don't want to add extra food. We will go back here. Imagine that the baby on the non-invasive respiratory support, which is most of the babies premature, either an invasive or non-invasive support. So what's going to happen here? You're going to further giving air. And further, you're gonna distend the abdomen. And that's just remember all these story when you deal with baby who's versus just baby came from outside who's completely full term, maybe the different story. But if the baby is in respiratory support, then it's gonna get worse. So the management of the bilious emesis, number one, nothing per mouth, NPO. That's a standard. Number two, you need to decompress. You need to take off the whole. If there is any baby on respiratory support, you need to take the air out. So you're gonna be decompression. Usually we call Reblogal catheter, which is large tube catheter, suction catheter, but usually bigger tube. Okay, depending on the size of the baby, 8, 10 French, depending on the size of the baby, okay? That suction connected with the suction, either continuous suction or low intermittent suction. Be careful when you use continuous suction, especially if your tube is close to this wall, you might create injury or erosion to the mucosa. So be careful, make sure that your tube is not too deep and not attached. Sometimes when continuous suction, you can create stress ulcer or you can create the erosion of the lumen. So usually we do low intermittent unless it's baby with low intermittent still abdominal distension, then you might place baby on the continuous suction, but there's no right or wrong answer, okay? Number 3, you need to do serial ultrasound or serial x-rays. The first x-ray, you need to do it based on the bilious, always do KUB, and then based on this x-ray, you need to do serial x-ray to see the extent, because always there's a risk of perforation. And if the perforation happens, then that's a true emergency. You need to send a surgeon, you need to do it immediate open lab or X-lab. So that's very important. NPO, Reblogal, and then X-ray and follow-up X-ray, 4 to 6 hours X-ray until figure out what's going on with the baby. It's very important for any surgical related issues is IV fluid and correct the electrolyte imbalance. If you are concerned about microperforation or abdominal distension, because sometimes what happens, the cause of the abdominal distension, especially in babies, is just ileum or ileus, sorry. It's ileus, that means it's just slow motility and either electrolyte imbalance or sepsis that just thinks is not moving. It's not, doesn't have to be through through atresia or mechanical obstruction. Sometimes it's just ilia. Baby just slow down and is not moving, thinks it's not moving, and then impact of the food. So always, if you think of the either ileus, especially if it's related to the infection, or baby is going to go to the surgery, then it's good to cover with the antibiotic. In small baby, usually majority of time, we give the Zosyn to cover aerobic and anaerobic because you don't know what you are dealing with, okay? Other electrolytes, as a diagnostic approach, you need to do the whole complete metabolic panel, including the kidney function because baby might be dehydrated. You need to do CBC if looking for the infection, biliary or bilirubin, especially if there's sepsis, you might have the component of the direct hyperbilirubinemia. If the baby all of a sudden was completely fine, abdominal distension, you need to do blood culture and start antibiotic, as I said, blood culture to make sure there's no true sepsis. And then if the babies go to the surgery, usually it's not common unless it's a big surgery, blood type and screen. And then very rare, if you are suspicious, especially meconium ileus, you might ask for the cystic fibrosis test, but that's usually late, so it's not as an initial workup, okay? Very good. So we decided to do the X-ray. The X-ray approach, either you have double bubble sign or multiple dilated loops, or either specific or non-specific. If you have double bubble sign, then you can ask yourself, okay, there is double bubble sign. Anything below, if nothing absent, then you are dealing with duodenal atresia. If you see double bubble sign, that's the stomach. And then like this, so that's one bubble, and that's the second bubble at the antrum. Then, and there's nothing below, you are talking about duodenal atresia. That's number one. Is that clear? Very good. If you see triple bubble sign and nothing below, you are thinking of jejunal atresia. Triple. Okay? So that's very clear. Easy to diagnose. Double bubble, I'm dealing with duodenal atresia, and we will discuss about it. Triple bubble sign, you are talking about, and nothing distally, that means small bowel obstructions, till improve otherwise. And you know the diagnosis, that's the easy piece of cake. If you have like those cases, you know what you are dealing with, we done. If you have the double bubble sign or non-specific, and then you have the gas down distal, there is already, then you need to think that means most likely is not a true atresia. It could be some obstructions, okay? Something from outside or stenosis. Then you need to do the upper GI serial. So double bubble signs or non-specific with distal air, then that means whenever here there's some obstruction, it's not complete occlusion. That means the gas start going down, then you need to do upper GI serial, okay? If you have multiple dilated loops, especially if you have fluid levels, then you, in the same way, is it just included the upper part, nothing distal? That means there's intestinal obstructions, and most likely you are dealing with ileal atresia, or any obstruction, doesn't have to be atresia. But since the, or usually at either severe obstruction or atresia. But here, the distal or valvulus, but because there is no gas, nothing distally, that's the clue, there is nothing, there's no way the air comes down. That means completely obstruction or valvulus, or you are dealing with ileal atresia or colonic atresia. Then you always start with lower contrast enema. Versus if you have a distal, then you think, okay, there is, it could be mechanic, it could be some obstruction, but partial obstructions, it could be hairspring, it could be anything. So because I'm still seeing the baby air all the way down, then you start with enema, Very few, very limited, you might need upper, but usually just do the enema, and usually you can figure out. And a lot of time, you don't know what's going on. So it's not like conclusive, this baby has this, I'm 100% sure. A lot of time, we know there's some sort of obstructions. The surgeon say, I need to do X lab, and then he will figure out what's going on with the baby. But for you, or for as a neonatologist and the surgeon, we need to figure out, is it surgical or non-surgical case? Is it through surgery or just ileus? Okay, very good. Most cases, if we decided to do the contrast enema, we used low isoosmolar water-soluble contrast enema. Occasion, when you are thinking this could be meconium, we use gastrographene, hypertonic agent that can be used as diagnostic or therapeutic. We don't usually cause, or no longer recommended to cause, to use the contrast or the barium enema, sorry. We don't recommend anymore the barium enema, because the barium enema, if the baby has perforation, that can cause peritonitis. So if you see barium enema, always wrong, okay? So barium enema is usually is not recommended anymore, recommended because there's small potential this baby might have perforation, or if you give enema and then baby had the perforation, you might end up peritonitis. Okay, so we will talk now about the first differential diagnosis is the duodenal double bubble signs, nothing distal, that's the duodenal atresia. It's occur in 20,000 to 40,000 birth. It's isolated finding in around 1/3 of patients. People, they love it for the board, by the way. Number one, because they have characteristic double bubble sign. And we know why double bubble sign. Here, the first bubble, and then there is second bubble, and then completely atresia is nothing. So that's the antrum. So that's the double bubble sign. Food accumulation here, and then you will see air, double bubble sign. People, they love it because it's associated with all characteristic of the duodenal. So just D criteria. What's D? Duodenal atresia started on usually in the first day of life, because early. It's all the way to duodenum. It's not all the way down. So baby presentation usually early. Associated with D, Down syndrome. You will have a D double bubble sign. Treatment, decompression, duodenectomy. So everything is D. But the most important, people, they love it in the board, is the associated with the Down syndrome or malrotation. Okay? So it's 1/3 of cases, isolated finding, but also it's important to rule out when you have duodenal atresia, you rule out the other causes. Cardiac, 30% of cases. Esophageal atresia, 10% of cases. Genitourinary, around 11 or 12%. Annular pancreas, 20%, okay? But the most important, make sure the baby clinically doesn't look like Down syndrome. What happened in the duodenal atresia? So duodenal atresia, it's happen early during around 6 weeks. If you understand the pathophysiology or embryology, how it's occur, it's easy for you later on to think about it. So initially, early in the development of the intestine, the gastric tube or the intestinal tube was hollow, empty. Here, nothing, okay? And then after that, epithelialization, hyperplasia, and hypertrophy of that area. So the tube's completely filled, so become blind loop. And then after that, the apoptosis occur, and the lumen start obliteration and empty again. Around 9 weeks, it's become hollow. Failure of recanalization, that's when you have atresia. So it's appear early, around 8 to 9 weeks of gestation. Secondarily, failure of recanalization, or even here. So around any time in that period, When the apoptosis does not occur, does it remain blocked completely, that's when you have the duodenal atresia. The same principle for the stenosis. It's just open, but it's not complete. So duodenal atresia start early in pregnancy. So when you think about it, is it true emergency? I have to take the baby today to the OR? The answer is no, because that baby has been forever. He has the duodenal atresia. So that means it's not true emergency. You can wait even second day as long as you control electrolytes. You call the surgeon, yes, you need to inform them. If they want to open today, it's fine. If they said correct electrolytes, if you don't have pediatric surgery today, that's fine to wait because it's been forever. He has the atresia, okay? And nothing, there's no vascular ischemia. You're not gonna lose bowel. It's already there, atresia, okay? So that's not, as long as you hydrate the baby, MBO, decompression, you hydrate the baby, nothing per mouth, that's the basic structures or basic management, okay? When you have a duodenal atresia, is it bilious or non-bilious? We discussed, correct? So this is the, here, ambulovata, so that's the bile, a bile all the way, and the baby's first few days, baby has bilious, non-projectile or bilious vomiting. Antenatal, because of the baby has atresia, you will have, anytime you have intestinal complete sign obstruction, you will have polyhydramnios, especially the upper small intestine or any small intestine mainly, or the esophagus. So baby will have polyhydramnios. Sometimes even antenatal, if you have a good antenatal center, they might discover double bubble sign antenatally. When they do the ultrasound, you might see double bubble sign. Postnatal, we discussed bilious vomiting in the first 24 hours of life, abdominal distension, yes or no, you could be, it could be no. So that's not always there, okay? And baby might or might not, if severe, you might not have. Baby Bass meconium, it might be, depend on the timing, but usually you will still, does not rule out the pyloric stenosis. We said the diagnostic, do x-ray. When you have the x-ray, that's more than enough, okay? The most important, no distal air under. So just double bubble sign. And we discussed around failure recanalization, and we usually occur on the second part of the duodenum. That might be a board question, okay? We have 4 types, that's based on animal study. There is 4 different types, 3 different types of the pyloric stenosis. Number 1, it could be just blockage like web. Number 2, just band. Number 3, completely separation of the duodenum. Okay? So number 1, either web or stenosis area. Number 2, just band. Number 3, complete separation. How we treat? Easy. As any intestinal obstruction, MBO, gastric decompression. So you're gonna take everything is out. Usually low intermittent suction. Unless you have a lot, then you might involve the surgery. Call the surgeon. Consult, surgical consult. You say, hey, this baby already, and electrolyte, correct electrolyte. MBO, start fluid. And electrolyte, if there's any electrolyte imbalance, correct it. The surgery, what they do, usually you already have the atresia portion. You're just gonna be duodenostomy. You bring the both together and you open the canal. Is that clear? Okay. Let's talk about now the rest of the small bowel obstruction. So we spoke about the duodenum. Now we're gonna talk duodenum, first, second, third part, and then now we are on the jejunum, and then later on we're gonna talk about the ileal part. And be aware of the ileocecal valve. We said that, okay, we discussed about no double bubble sign, you just have multiple fluid level. Ask yourself, any bowel, any gas down, there is nothing. So now you are dealing most likely with small bowel obstruction. And since you can see the bowel all the way to here, most likely we are dealing with the ileal atresia or ileal obstructions, or the obstruction at the level of the ileum. But is that enough to say this is the ileal atresia? Not enough. So after this one, you will have baby who comes few days, starts non-bilious vomiting. Is it bilious or non-bilious? Depend, correct? So it could be bilious, it could be non-bilious, but mostly it's going to be everything is out. So it's going to be vomiting, bilious vomiting. Abdominal distension, loopy bowel. Then you examine the baby, whether baby has true surgical perforation or just non-specific abdominal distension, whether there's a tender or guarding abdomen, that's the different. You decided, okay, I don't like it. There's fluid level, most likely surgical. There's intestinal obstruction. Let me keep baby MBO. That's number one. Let's do the reblogal catheter to decompress, because you can see this big bowel. It can also push the intestine, the respiratory up, and then maybe baby will have some atelectasis and respiratory distress just because the abdomen is full and pushing everything, and baby cannot breathe. Like a pregnant woman, she cannot breathe. That's the same as pushing everything up. And baby, especially tiny baby, they have low reserve, so they can push down. So you need to help them out. So you need to gastric decompression. Okay, and then so we place the catheter, reblogal catheter, to decompress. We said we're gonna keep baby MBO, and then after that you're gonna call the surgeon, and most likely she will say, let's do the contrast enema to see what's going under here, what's going on there in the colon. Sometimes those overlap, so what's going on with the colon. Okay. So let's talk each one, and then we will see what's next. So now we're going to talk about jejunal and ileal atresia. Which one is common? Jejunal atresia or ileal or jejunal atresia? The ileal or jejunal atresia is usually common. You can see here 1 to 1,500 to 5,000 birth. It's not like 20 to 40,000 birth. Male to female is equal. The most common, and that might be board question, the most common involved, the area involved, it's the distal ileum. Where's the distal? When we say distal ileum, that means we are close to the ileocecal valve, okay? So just keep on your mind. It's too easy to remember. Whenever the answer is close to the ileocecal valve, that's the most common side of the obstructions. In contrast to the jejunal atresia, we said common with Down syndrome or other anomalies. The ileal atresia less likely to have chromosome anomalies. It doesn't have to be completely atresia. It might be obstructions secondary to that. If the baby has cystic fibrosis, you might have a very thick meconium that drain the fluid out, is very dry. It might obstruct the ileum, especially the terminal ileum, because meconium ileus. It could be gastroschisis associated with ileal atresia, midgut valvulus, intestinal perforation, and or peritonitis that's seen in the, can be linked. If the mom, she's on drugs or the vasoactive or vasoconstrictive drugs, that might cause obstruction. So that's the, if the mom on taking cocaine or vasoactive, that can cause vasospasm and atretic to the mesenteric blood vessel, and that can cause atresia. Okay. If the baby antenatal have the valvulus, that might cause interfere or interruption of the vascular blood supply to that area and might cause atresia. If the early intussuscipitate meconium, it's early intrauterine and that interfere with the blood supply to the region, it might be atrophy and then it might create atresia. Okay, so the in utero, the cause is it's appear late. So the whole bowel, it's already formed. It's not like the jejunal atresia super early. This one is in utero. What happened? It's mesenteric vascular occlusion and usually single. So that means either portion, one occluded, or multiple occlusion. And we will talk about the different types. So here it's atretic. That means completely obstructions. Okay. And why we are talking about superior mesenteric? Because we need to remind ourselves early in pregnancy, very early in pregnancy, when you have the gastric tube, and we discussed in the last presentation, you have foregut, midgut, hindgut. We said that the abdominal aorta, the foregut supplied by the celiac trunk, midgut supplied by the superior mesenteric artery, and the foregut supplied by the inferior mesenteric artery. Okay? So if there's, since we are talking about small intestine, so we are going to focus on the superior mesenteric. How baby is presented? 30% of time prenatally they might be present with polyhydramnios because of the more distal now the obstruction, especially with the ileal. Okay. Usually baby small, gestational age, presentation 24 to 48 hours with bilious vomiting. Baby, they might have, depend, if proximal, more jejunal, if distal, more ileal obstructions. May or may not pass meconium, depend on completely or not complete. And as I said, this happened late, so it might be still some meconium already. So that's the presentation. Okay, so we said that the baby with the small intestine or the ileal or jejunal atresia, usually presentation is the repetitive vomiting. First step of management is that to ABO decompression, we did the X-ray, non-specific, nothing here. Dilated loops. So if you see this one, 1, 2, 3, that's most likely jejunal atresia. Triple sign or triple, double bubble, triple bubble. Here, multiple fluid level, and there's nothing below. Then I will do the contrast enema. When we do contrast enema, I give a contrast. You can see there's some black here, stool. You will see the bowel is very micro, and you see there is contrast defect here. There's stool. There's another defect here. And you can see
ما فيش صورة تعرض.
ما فيش صورة.
ايه.
بكش انت النت عندك. ترى نشبحوا شنو كاتبين يا جماعة.
اوكي ما دام معناها عندنا المشكلة. خلاص تمام استمر.
اوكي. تو احنا قلنا درنا الكونتراست في feeling defect في stool. Whenever you see the feeling defect, most likely stool. But what we can see here, number one, the colon is microcolon. Why is microcolon? Because it appear early, correct? Is way early. That means the colon, unfortunately, if you are not use it, the colon is going to be very narrow, tiny, atrophic. So that's why number one, microcolon. Number two, there is feeling defect. That's most likely stool because it happens, we said it's late. It's not happen as a atresia super early. And then you can continue until you see this bar here, the cecum. And then after that, there is narrow and disappear. And you can see feeling defect here, all these areas. Let me take it out so you can clearly see. So you can see here. And then you see here the filling defect, and then completely stop here. So that means there is something obstruction here. And also what's interesting in this image, since you guys want, is that you can see there is here very dilated. So that's the proximal portion. Very dilated. You can see the proximal portion is very dilated, that we see it early in those images. So now we did the barium enema or contrast enema, not barium, sorry, contrast enema, I'm wrong, contrast enema. The contrast enema, what we said, number one, there is microcolon. That's very clear. You guys agree, correct? And where's the cecum? In the right position, slightly up, but right lower quadrant, cecum. So this one is not malrotation. Usually malrotation, you will see it right upper quadrant or epigastrum around here. So then you know that this is malrotation. The cecum all the way down in that position, right lower quadrant. So that means there is no malrotation. And then you will see the ileocecal valve, and then it's ending here, the bowel, nothing there. That's it. So that means there's obstruction. And then what else? You will see the dilatation all the way here. That's the proximal. So from this image, I can tell you that's baby needs stat, emergency, X-lab to open and see. Did we see any calcification outside? There is nothing. So that means there is no, if you see in utero or if you see perforation, small calcification, then that means there is micro perforation or in utero perforation with meconium, peritonitis. But here, there is nothing. Is that clear? Microcolon, I know, okay, that means nothing going below that level, obstruction, and bowel slowly lose motility and is not used. That's the get atrophic. So that's microcolon. Number 2, the cecum in the right lower quadrant, slightly up a little bit, but still in the right position. There's no malrotation. After that, I can see atretic or the narrowed and then disappear. So most likely, and then there's dilatation. So there's most likely, I'm talking at the level here, there is most likely severe, most likely is going to be شنو اللي هي ileal atresia or severe obstructions, volvulus at the level of the ileum. Then it's through emergency. I'm going to open and see, call the surgeon, or usually they involve it once they order, usually the one they want you to order the, so immediately when you have the double fluid level, you should involve them, not late after the contrast enema. You involve in the beginning and listen to their recommendation. Majority of the time they will say, let's do the contrast, and usually they want to be involved at the bedside to see the images. And then if they confirm it, okay, this baby need to take him to the OR, make sure you start fluid already, baby already MBO, baby already decompression and electrolyte correction, and then take the baby to the OR. Hopefully it's clear. The management of the ileal atresia or ileojejunal, surgical. Okay, it's gonna open, and then most time the surgeon, as I said, it could be one, it could be multiple atretic in multiple regions. So it could be one area atresia, or it could be there's multiple atresic area. So the surgeon, what they do, they open and then they explore the bowel to see if there's any atresia. They look at the other bowel, if there's any ischemic or if there's any necrosis in the bowel, and there's gonna be multiple atretic or no. Okay, any question? Okay, so since we start a little bit late, I'm gonna, do you guys want me to stop here? We said an hour, or continue for malrotation? Another 30 minutes, or we can stop here and then continue tomorrow, next week, sorry. Ayman, what do you think? Dr. Ayman? Guys, do you hear me? Yes, stammer, stop, stammer, stop. Okay, so let's stop here. Okay, and then since I would like to keep it 1 hour sharp, it just malrotation, it's a little bit dense, and then meconium. Okay, so let's stop here and then we can continue. The most important for me, you guys understand what I'm trying to achieve, and without stress you guys, and make sure that everybody on the same page. Okay, so we're gonna stop here and then we can continue the presentation tomorrow. Sorry, next week. Any question? Any question?